Embarking on a weight loss journey is essential to better health and an improved quality of life. This video provides key information for your first surgical appointment with the Callan Metabolic and Bariatric Clinic, CMBC. It will include information on the types of surgery available, alternative treatments, the risks and benefits of surgery, workups leading to surgery, before and after surgery care, weight loss goals, expectations, and weight maintenance. All this information will help you make an informed choice regarding whether surgery is right for you. The information provided will help you make the most of your first appointment with the surgeon. And you may like to write down any questions that come to mind to ask during your consultation. The indications for bariatric surgery include informed and well-prepared adults, high body mass index, BMI, and complex weight-related health issues. No smoking, which includes non-vaping. No alcohol or illicit substances. Stable mental and emotional health. Revisional surgery for weight regain or adverse effects of previous weight loss surgery. Bariatric surgery alone is not enough. Weight loss surgery is a major decision and requires a lifelong commitment to maintain a healthy lifestyle with close attention to healthy eating and physical activity behaviors, which often means a change in mindset and a focus on looking after yourself. Successful weight loss outcomes and weight regain prevention depend on long-term maintenance of a healthy lifestyle, which a multidisciplinary team of health professionals can support. Engagement with the CMBC dietitian and surgeon during the initial 12 to 18-month post-operative period, along with a psychologist, exercise physiologist, and your GP, is crucial to help optimize your weight loss outcomes, maintain ideal nutritional status, troubleshoot any adverse effects, including weight regain, and to avoid disappointments in expectations. You will usually have 1 to 2 consultations with the CMBC surgeon. The first assessment will discuss the suitability of surgery for you, assess the benefits and risks, review current blood tests and any relevant imaging, and the type of surgery most suited to your clinical situation. At this appointment, an endoscopy will be scheduled for you to evaluate the condition of the upper gastrointestinal tract to help ensure you are a suitable candidate for surgery and to help reduce potential risks. A second surgical consultation will allow a review of your endoscopy results, further discussion of whether surgery is suitable for you and what type, followed by informed consent, if deemed appropriate, to add you to the elective surgery waiting list. You need to continue to follow your treatment plan and aim not to gain any excess weight whilst waiting for your surgery to ensure you are optimized and as ready as possible. If you are female and of childbearing age, you must consider whether bariatric surgery is right for you and the timing of this. The recommendation is to avoid pregnancy for the first 18 months after your weight loss surgery due to the potential risks to the baby, including low birth weights and associated complications. All bariatric procedures carry potential risks at different times. Your surgeon will provide these risks to you again. Sleeve gastrectomy. Under general anesthesia and keyhole surgery, the bulk of the stomach capacity is reduced to a narrow sleeve or tube, which usually measures 1/3 to 1/2 of a cup volume. The stapled-off stomach is removed from the body, and this is irreversible. Weight loss occurs due to reduced appetite as hunger hormones are reduced, volume of food is restricted, and some malabsorption occurs from fast transit of meals. Sleeve gastrectomy includes the following risks. Your surgeon will provide these to you again. Roux-en-Y gastric bypass. Under general anesthesia and keyhole surgery, the stomach capacity is reduced by forming a small stomach pouch joined to the small intestine. Weight loss occurs due to reduced hunger, volume of food is restricted, and mainly via malabsorption of up to 2 meters of the small intestine. Roux-en-Y gastric bypass includes the following risks. Your surgeon will provide these to you again. 1. Anastomosis. gastric bypass. Under general anesthesia and keyhole surgery, the stomach capacity is reduced by forming a small stomach pouch joined to the small intestine. This is another type of gastric bypass. Weight loss occurs due to reduced hunger, volume of food is restricted, and mainly via malabsorption of up to 2 meters of the small intestine. One anastomosis gastric bypass includes the following risks. Your surgeon will provide these to you again. When weight regain occurs post-surgery, the first line of treatment is to refocus on dietary intake, regular physical activity, mental health, and medication management as a priority. Revisional surgery is only considered when these strategies are revisited and exhausted. Revisional bariatric surgery may have various indications, but usually there are 2 common reasons. Regain of excess weight following index weight loss surgery. To remedy the adverse effects of a previous primary surgery. Some examples of revisional bariatric surgery are previous gastric band removal and conversion to sleeve gastrectomy or gastric bypass. One anastomosis gastric bypass conversion to Roux-en-Y gastric bypass. Sleeve gastrectomy conversion to gastric bypass. Vertical banded gastroplasty conversion to gastric bypass. Revision surgery carries a higher risk than a previous primary bariatric surgery due to many factors such as pre-existing adverse effects from the first surgery, altered surgical field, scar tissue, and different surgical technique from a previous surgeon. Surgical outcomes from revisional bariatric surgery can be challenging to predict accurately and may be suboptimal. For example, average weight loss after a second revisional bariatric operation may be below that predicted when compared to averages for a primary bariatric operation of the same type. Other procedures that may be required during your weight loss operation may include the following. Endoscopy, where a camera is passed through the mouth to look inside the stomach. Division of scar tissue inside the abdomen. Removal of the excess part of the stomach or bowel. Removal of the gallbladder. Repair of hiatus hernia, umbilical hernia, or incisional hernia. If additional procedures are anticipated, particularly with revisional cases, your surgeon will discuss the rationale and risks benefits with you during consultation. Once you receive a surgical date, you will be sent a range of resources and video links to watch in preparation for your first preoperative dietitian appointment. You will then consult with our dietitian to support commencement of a preoperative very low energy diet, VLED, under supervision. This will include using VLED products, shakes, soups, bars, to replace all your meals for usually 3 to 4 weeks before the surgery date. It is essential to strictly follow the VLED instructions as they help reduce the liver bulk, reduce complications, and support your recovery. Generally, patients lose 1.5 to 2 kilograms per week with a VLED and usually experience an 8 to 12 kilogram weight loss before their procedure. In rare cases, if liver bulk persists and surgery cannot be carried out safely, the procedure may be postponed. You may also receive a consultation from our anesthetist if they have any anesthetic concerns about your fitness for surgery, and further investigations may be required to carry out your procedure safely. It is also vital for you to discuss an updated list of medications during all your consultations with our team, as some of these will be affected before and after surgery. You should consult your GP if unsure about your medications before commencing the VLED. Commonly affected medications are noted below. Some diabetes medications and insulin must be stopped at different times, and before starting the VLED, blood sugar levels tend to reduce after surgery, and most diabetes medications are no longer required. Weight loss medications such as Ozempic, Wegovy, and Mounjaro will require a special pre-anesthetic protocol, which you will be advised of. Most blood thinners will need to be stopped at different times and should be discussed. Aspirin may be continued, but dual antiplatelets such as clopidogrel must be stopped. Over-the-counter herbals such as fish oil should be ceased at least 2 weeks before surgery. Non-steroidal anti-inflammatory drugs like Brufen and Voltaren should be avoided and ideally stopped but if necessary, then they can be used under antacid medication cover, such as Nexium or Somac. High blood pressure medications are to be taken as usual before surgery, but the dose may require adjustment with your GP in 2 to 4 weeks, as blood pressure tends to reduce after surgery. You are required to fast from meals for 6 hours before your approximate surgery time. You may take medications as discussed with the team earlier and can take water alone until 2 hours before the surgery. All procedures are carried out under general anesthesia, with local anesthesia for pain control after the procedure. It is standard practice to administer antibiotics to reduce infection risk and use calf stimulators to help reduce clot risk at the start of the procedure. In the majority of cases, the procedure is laparoscopic, called keyhole, usually with 5 or 6 incisions, to help recover faster and reduce discomfort afterwards. Rarely, an open procedure is necessary due to scarring inside the abdomen from previous surgery, the complexity of surgery, or if there is a safety concern during the procedure. Dissolving sutures are used to close skin incisions and do not need to be removed. Waterproof dressings are applied to enable showering. During your hospital admission, your diet will initially include free fluids the day after the surgery, and you will go home on a pureed diet. You will see our dietitian approximately 3 to 4 weeks after your surgery. We encourage same-day walking and drinking water on the evening of surgery. There may be shoulder tip discomfort from gas trapping, which usually subsides in 3 days. A heat pack may be helpful. Patients are typically discharged home within 1 to 2 days if everything goes well. If you live remotely, more than 30 minutes away from your nearest hospital, consider adjusting your accommodation accordingly for a week. Regular pain relief may be needed in the first week for faster recovery, but you should notice an improvement every day. You cannot swim for the first 2 weeks or until the skin is healed. Driving is permitted after 7 days, provided you are pain-free and not taking sedating medications. You may wish to check with your insurance company regarding any fine print for coverage after an operation. Heavy exertion should be avoided for the first 4 weeks after surgery, limiting carrying weights to under 7 kilograms. Light exercise such as walking, gentle stretching, and light jogging without core abdominal use may be permitted in the first 4 weeks, and then you will be able to gradually increase activity levels in the second 4 weeks. In the second 4 weeks, moderate activity may be sustained, such as lifting 15 kilograms, running on a treadmill, cycling with graduated moderate core abdominal exercises. After 8 weeks from surgery, there are no restrictions on physical exertion. Returning to work depends on the type of work you are involved in. Sedentary office and desk workers can return to work as early as 7 to 10 days. Manual workers who are required to lift weights may need to wait between 4 and 8 weeks per physical exertion limit mentioned above. A supporting medical certificate can be provided on request, and patients commonly need 2 weeks of rest after surgery. Bariatric surgery is considered a tool to help your weight loss efforts and requires your lifelong commitment to maintain a healthy lifestyle and optimize surgical results. Expected average weight loss outcomes with a sleeve gastrectomy are around 40 kilograms and with a gastric bypass around 50 kilograms. The metabolic weight loss effect of surgery is at its peak in the first 12 months post-surgery and will diminish over time, ceasing around 12 to 18 months after surgery. Inadequate weight loss, excessive weight loss, and weight regain can be as high as 30 to 40%, and you should seek early advice and intervention in this case. Revisional surgery may not meet average weight loss outcomes, as the patient's metabolic system is exposed to a second procedure by its nature. Although revisional surgery does carry greater risk, serious complications in primary bariatric surgery, such as bleeds, leaks, and infections requiring intervention, are rare, less than 1%. It is strongly recommended that you actively engage with the CMBC team to optimize your outcomes. Care provided by the CMBC team will continue for approximately 12 to 18 months post-operatively. Following this, you must continue with regular follow-up in conjunction with your GP and a range of health professionals through the support of your GP, including a private dietitian, yearly and lifelong, and private exercise physiology and psychology support. Regular weigh-ins and lifelong bariatric-specific multivitamin supplementation are required to support safe management following surgery. Factoring in the cost of these supplements for the rest of your life is an essential consideration for surgery. In addition, bariatric surgery can have a profound effect on body image, size, self-esteem, social connections, relationships, eating out, and mental well-being. The journey is both physical and emotional. Asking questions, utilizing your support team, and researching will help you understand and support you in making a well-informed choice of whether surgery is for you. Thank you for watching this video.